Welcome. In this session, we are going to discuss the remaining entities under non-infectious posterior uveitis. So starting this session with Birdshot chorioretinopathy, also called vitiligionous chorioretinitis. This entity is more common in females later in life in 5th decade and beyond, and it has a strong association with HLA-A29. This association is the strongest HLA association among any human disease. HLA-A29 is confirmatory of Birdshot chorioretinopathy but is not diagnostic of Birdshot chorioretinopathy. Patients of Birdshot complain of photopsias, floaters and blurred vision, and characteristically they have nyctalopia and color vision disturbance later on. Lesions of Birdshot are multiple and are described to be ovoid and cream colored at the level of ARPE and choroid. They occur in the post-equatorial fundus, and a characteristic feature of the lesions of Birdshot is that they do not become hyperpigmented, unlike the lesions in other posterior uveitis entities. Another characteristic of Birdshot is that the lesions are predominantly nasal to the optic disc, more so inferonasal to the optic disc, and they appear to be radiating away from the optic disc, which is described as a shotgun pattern. So we find the lesions to be nasal to the optic disc and radiating away from the optic disc. This is another picture of Birdshot retinopathy. So we find lesions in the post-equatorial fundus, more nasally, multiple, cream colored and ovoid, and appearing to radiate away from the optic disc. There can be associated retinal vasculitis, vitritis, macular edema and optic nerve edema, and they may actually be clue to the diagnosis of BCR among posterior uveitis entities. Complications include chorioretinal atrophy, attenuation of retinal vessels, optic atrophy, and rarely choroidal neovascularization. OCT shows early choroidal thickening and late choroidal thinning. There is disruption of the ellipsoid or the ISOS zone. Macular edema, macular atrophy and epiretinal membrane can also become visible on OCT. OCT angiography shows reduction in vessel density in the deep retinal capillary plexus level. In fundus fluorescence angiography, there is a delayed retinal circulation time, and the lesions show early phase hypofluorescence and late phase hyperfluorescent staining, the typical pattern in most of the white dot syndromes. On fluorescent angiography, we may also be able to detect retinal vasculitis, macular edema, optic disc leakage and choroidal neovascularization. On ICG, the lesions show hypocyanosis, and fundus autofluorescence show hypoautofluorescence of the atrophic lesions. So here we see atrophic lesions in the fundus autofluorescence. This photograph is taken with infrared rays, thus making the lesions more clearer, and late phase fluorescent angiography shows disc leakage, vasculitis and macular edema. In this picture we see ICG angiogram showing hypocyanescent spot corresponding to the clinically visible lesions, which later disappeared upon resolution following treatment. Treatment is initiated with systemic steroids, but most cases require early institution of immunomodulatory therapy. Birdshot chorioretinopathy has a chronic or recurrent progressive course, and the visual prognosis is usually guarded. Monitoring of Birdshot is recommended with full-field electroretinography and automated perimetry. Full-field electroretinography shows increased implicit time of 30 Hz flicker response depicting the cone response and reduced scotopic B wave amplitudes. The mean deviation plot in 32 automated perimetry is recommended for monitoring Birdshot, and we may also find central scotoma, peripheral constriction, generalized depression and enlarged blind spot. The next white dot syndrome we are going to discuss is multiple evanescent white dot syndrome, also known as MEWDS, and it typically occurs in young myopic females, and it is one of the few white dot syndrome entities which is unilateral. Patients complain of acute onset of blurring of vision, as well as central and paracentral scotoma and photopsias. 1/3 of patients may have prodromal symptoms, like in APMPP. Lesions of MEWDS are multiple, discrete, white to orange, and at the level of retinal pigment epithelium. They are mostly perifoveal in location but may also be present more peripherally. and the lesions are transient in nature. One very characteristic feature of MEWDS is the granular appearance of macula, and this is pathognomonic and usually persists after the lesions disappear. In fundus fluorescent angiography, lesions of MEWDS show early phase hyperfluorescence, unlike other white dot syndromes with hyperfluorescent staining in the late phase. The stained lesions are arranged in a wreath-like fashion around the fovea. So this is the wreath-like arrangement of the lesions in the fovea. In indocyanine green angiography, the lesions show hypocyanosis, and there can also be peripapillary hypocyanosis. On optical coherence tomography, we find disruption of the ellipsoid zone at the site of the lesions by dome-shaped hyperreflective material in the ellipsoid zone pushing towards the outer nuclear layer. However, octa features are normal. In FAF, lesions of MEWDS show hyperautofluorescence, but there may be some hypoautofluorescent spots also around the optic nerve and in the posterior pole. Paracentral scotoma and enlargement of blind spot may be demonstrated on visual fields, and on electrophysiology we may find diminished amplitude of A wave and early receptor potential. MEWDS is self-resolving and treatment is not required. Episodes of MEWDS lasts for 2 to 10 weeks and recurrences are uncommon, and visual prognosis of MEWDS is excellent. However, photopsia and enlarged blind spot can persist. Now we come to a few lesser known entities which also belongs to white dot syndromes, because some of their features are similar to the other white dot syndromes which we have already described. Among them we have acute macular neuroretinopathy, which occurs in young females, and patient complains of acute onset of blurring of vision and multiple scotomata. We find flat reddish brown wedge-shaped lesions with the pointed edge of the wedge towards the fovea, and this is better seen in infrared imaging. On OCT we have disruption of ellipsoid zone with hyperreflectivity of the outer plexiform and outer nuclear layers. Octa shows vascular compromise in deep capillary plexus of retina. However, fluorescent angiography and indocyanine angiography results are normal. Paracentral scotomas are found on visual field, ERG is normal, and AMN is self-limiting and no treatment is recommended for AMN. Then we have acute retinal pigment epitheliitis or ARPE, also called Krill's disease, which occurs in young adults, and it is also unilateral. So we have two entities among white dot syndromes which are unilateral, MEWDS and ARPE. The patient complains of sudden onset of unilateral blurring of vision with central scotomata and metamorphopsia. There is absence of vitritis, and we find multiple discrete lesions in the posterior pole. Each lesion consists of a hyperpigmented center with a yellowish halo, and this is the characteristic of ARPE. In FFA we find early phase central hypofluorescence and late phase halo of hyperfluorescent staining. ICG shows early phase patchy hypercyanescence and late hypercyanescent halos. FAF shows variable hypoautofluorescence, and visual fields usually demonstrate central scotoma. On OCT we find localized disruption of the ellipsoid zone with wider disruption of the RPE layer. ARP is also a self-limiting disorder, and so it does not require treatment, and it usually resolves in 6 to 12 weeks. Acute zonal occult outer retinopathy or AZOOR is a clinical entity which usually does not have any visible signs in the early stage of the disease, and this is why it is termed occult. It usually occurs in young myopic females and is initially unilateral, and later the other eye becomes involved. Patient complains of sudden onset of photopsia and visual field loss. Mild vitritis can be present, and as we have mentioned, in early stage fundus is essentially clinically normal, but there are zones of outer retinal dysfunction which can be observed on diagnostic tests, and from this the term zonal is derived. Later on in the disease, these zones, which are essentially clinically normal in the early stage but show outer retinal dysfunction on diagnostic tests, develop RPE depigmentation visible clinically, and these zones of ARPE depigmentation have curvilinear margins separating them from normal areas of retina. Retinal arterial attenuation is seen in late stages, and AZOOR is often associated with systemic autoimmune diseases. So here we find peripapillary ARPE changes later in the disease. Visual field testing in AZOOR typically shows enlarged blind spot. Paracentral defects may also be found. ERG shows increased implicit time of 30 Hz flicker response reflecting compromised cone function, and EOG is also abnormal. Early stage AZOOR usually shows only a prolonged retinal circulation time on fluorescent angiography, and later stages reveal transmission defects correlating with the location of the ARPE depigmentation. Now in AZOOR, trizonal pattern is described for ICG, OCT and fundus autofluorescence. Trizonal meaning the normal area, the subacute area and the inactive area. Indocyanine green angiography shows hypofluorescence of inactive areas with minimal late leakage of subacute areas and normal appearance in normal areas. On OCT, early lesions of AZOOR showed disruption of the ellipsoid zone, loss of outer nuclear layer and thickening of the outer plexiform layer, and late AZOOR lesions in OCT show a trizonal pattern. In the inactive areas, we have retina, choroid and ARPE thinning, drusen-like ARPE elevations in subacute areas, and normal retina outside the zone of involvement. FUF also shows a trizonal pattern with central hypofluorescence, a peripheral rim of speckled hyperautofluorescence, and normal autofluorescence beyond. Efficacy of anti-inflammatory therapy is not proven, and the prognosis of AZOOR is said to be guarded. Acute idiopathic blind spot syndrome is a related disorder in which a patient has a monoocular scotoma temporal to fixation and photopsias. Clinically, the fundus appearance is usually normal, but the visual field shows an enlarged blind spot, and ERG also reveals reduced A-wave amplitudes. Acute idiopathic maculopathy will be the last of the white dot syndromes we are going to discuss, and it also occurs in young individuals with no sex predilection. Patients complain of sudden onset of severe central visual loss, usually preceded by a flu-like illness. We find a serous retinal detachment without vitritis, and upon resolution, ARPE discoloration and bullseye pattern of ARPE changes is often found. FFA in acute idiopathic maculopathy shows early phase progressive hyperfluorescence of ARPE followed by late phase pooling of dye in the subretinal space of the serous retinal detachment. On OCT, there will be a serous retinal detachment with disruption of the ellipsoid zone. AIM is a self-limited disease with good visual prognosis. Coming to collagen vascular diseases, these are systemic occlusive or necrotizing vasculitis with secondary involvement of multiple organs. Systemic lupus erythematosus usually presents with rash, arthritis, nephritis with hypertension or CNS involvement, but any organ may become involved in SLE, and the diagnosis is essentially clinical. In SLE, intraocular inflammation per se is rare. However, we find hypertensive retinopathy with cotton wool spots with or without intraretinal hemorrhages. Arterial and venous thrombosis can occur from hypercoagulability, and this may lead to ischemia, neovascularization and vitreous hemorrhage. Choroidopathy can occur leading to serous detachment of the retina and or RPE, choroidal infarction and choroidal neovascularization. Ocular drug toxicity can occur from drugs used for treatment of SLE such as steroids and hydroxychloroquine. Secondary Sjogren syndrome with dry eye can occur, and other ocular involvements which can occur in SLE are scleritis, optic neuritis and cranial nerve palsy. Polyarteritis nodosa usually involves the skin, the peripheral nerves, kidney and the gastrointestinal tract, and ocular involvement of polyarteritis nodosa include hypertensive retinopathy and choroidopathy, retinal vasculitis, inflammation of the optic nerve or more posteriorly in the optic tract, cranial nerve palsies, Horner syndrome, scleritis, peripheral ulcerative keratitis and sclerokeratitis. Wegener's granulomatosis, also known as granulomatous polyangiitis or GPA, typically involves the sinuses and the lungs. The kidneys and the nervous system can also become involved, and for diagnosis of Wegener's granulomatosis, C-ANCA is a useful marker. Ocular involvement of Wegener's granulomatosis includes keratitis with or without peripheral ulcerative keratitis, orbital involvement from adjacent sinus involvement, hypertensive retinopathy and choroidopathy, compressive optic neuropathy, and 10% of Wegener's granulomatosis patient can have uveitis. Suzak syndrome is also known as secret syndrome, standing for small infarctions of cochlear, retinal, and encephalic tissues. It is a rare entity occurring predominantly in young females, and Suzak syndrome is described by a triad of encephalopathy, sensory neural hearing loss, and branch retinal artery occlusion. The branch retinal artery occlusion in Suzak syndrome is characterized by diffused or localized narrowing of retinal artery with segmentation of the blood column within the retinal artery. However, there is no evidence of embolism or vasculitis. Fluorescent angiography shows non-perfusion of arterioles with staining of their walls, and there is no vitritis. Autoimmune retinopathy can be paraneoplastic or non-paraneoplastic, and in paraneoplastic retinopathy, we have cancer-associated retinopathy, most commonly associated with small cell carcinoma of lungs, and melanoma-associated retinopathy. Non-paraneoplastic autoimmune retinopathy is usually associated with systemic autoimmune diseases. Patients with autoimmune retinopathy complain of bilateral progressive visual loss with photopsias, nyctalopia, and dyschromatopsia. Initially, the fundus may appear normal. Later, arteriolar attenuation, ARPE mottling, diffuse retinal and optic nerve atrophy develop, resembling retinitis pigmentosa. Cancer-associated retinopathy shows a diminished cone response in electroretinography, and melanoma-associated retinopathy shows a diminished B wave amplitude called an electronegative ERG with only the A wave present. Serum autoantibodies to retinal antigens such as recoverin can be detected, and treatment includes anti-inflammatory therapy, but efficacy is uncertain, and prognosis of autoimmune retinopathy is guarded. Thank you for listening.